Hello everyone, and welcome to Ovarian Cancer Australia's new initiative, Webinars. We would like to acknowledge and thank the Brockhoff Foundation for providing OCA with the funding opportunity to deliver a suite of 6 webinars. This program of 6 webinars will cover a range of topics specifically tailored for women with ovarian cancer and their support networks, which will be streamed live online and then be made accessible as an online information and education resource nationwide. We are very excited to be bringing this webinar to you today, and thank you all of you for taking time out of your busiest day to join us now. We are pleased to welcome our presenters for today, Professor David Bertel and Robin Dennis. Robin Dennis, an ambassador for OCA, is living with ovarian cancer and is passionate about improving the lives of other women living with the disease. She understands the feelings of isolation that can occur after a diagnosis and feels very strongly about promoting awareness of ovarian cancer and how to live well with the disease. Professor Bertel holds a joint appointment as a group leader and senior principal research fellow at the Garvan Institute for Medical Research, and is also head of the Cancer Genomics and Genetics program at the Peter MacCallum Cancer Centre. He was director of research at Peter Mac for a decade from 2000 to 2009. Professor Bertel has an extensive background in human cancer genomics. He is principal investigator for the Australian Ovarian Cancer Studies, AOCS, one of the largest population-based cohort studies of ovarian cancer in the world, involving over 3,000 women, and Cascade, a rapid autopsy study. His work is part of the International Cancer Genome Consortium, an ambitious program to map the genomes of 50 most common cancer types. Professor Bertel's research has focused on the classification of ovarian cancer and mechanisms of primary and acquired drug resistance. Now, this webinar is live and interactive, and you are encouraged to participate by posting questions to the presenters, which can be typed into the chat box, which is located at the bottom left-hand side of your screen. Questions will be answered at the end of each speaker's presentation segment, and if you have any questions, you can submit them via the chat box to ensure they are answered. If you're experiencing any difficulty hearing the sound through the webinar, please dial in the 1-800 support number listed in the chat box now. And I'd like to pass you over to Professor Bertel to begin. Please go ahead.
Okay. Thanks very much for that. I meant to ask, can the participants see my arrow if I move it on the screen? Hello? Okay.
No. So if you'd like them to see you pointing to on your slides, you will need to click on the pencil button and then activate the laser pointer, which is the red dot.
Okay. The red dot. Okay. I see. All right. So is that now showing up?
That's correct.
Okay, great. All right, let's take it away. Well, good morning, everyone. Hopefully you can see and hear what I'm doing. This is the first time I've actually done a webinar with this group, so I hope it goes okay. We've got a reasonable amount of ground to cover in just 20 minutes, and so I understand these slides will be available to go over them at other times, and of course, be very happy to answer questions in the available time. So let's get going. So I think my role is to try and demystify what ovarian cancer is, and particularly explain the improved understanding of this disease, because it has very important practical implications for patients and their family members. So this is a subtitle, Getting to Know the Enemy. I think if you want to defeat the enemy, you really need to know its strengths and weaknesses, and that's very much what our work and others in the field is about. As mentioned, I'm mainly based at the Peter Mac, and we're about to move into our new home, but I also spend a week a month up at Garvan in Sydney. So the things I'm going to cover are essentially explain a little bit about what we now understand of the different types of ovarian cancer. This is a very diverse disease, and that's practically important for biologists like me, but it's particularly important in the clinic as well. I'm going to say a little bit about the genes that affect the risk of developing ovarian cancer, what we're learning about genes that influence whether patients respond or not to treatment, and the development of drug resistance, which unfortunately very frequently occurs in this disease. Okay, so the first thing is about the different types of ovarian cancer. So for hundreds of years, really, the diagnosis of cancer has really been based on anatomy. So what's shown in this picture here, it's just a schematic of different parts of the body where cancers can arise. So breast cancer is a common one, melanoma in the skin, prostate cancer in males, and so on. And so if you think about it, the starting point for someone's diagnosis of cancer is really an anatomical description. They've got kidney cancer, prostate cancer, lung cancer, and so on. The other thing that's very important, or has been very important, is the pathological assessment of the cancer when it's removed from a patient, either by a biopsy or during surgery. And what's shown here is the sectioning through a tissue sample. All these people here are pathologists, and they're looking at the pattern of cells in the cancer sample after it's been stained with some dyes, because those patterns can give a lot of information about the cancer, which type of cancer it's likely to be, and how it's likely to progress, whether it'll come back, whether it'll respond to treatment, and so on. So this is very much the sort of the 20th and early 21st century way that cancers are diagnosed. So when you take that kind of approach, and we're not going to go through all of this obviously, you can see that ovarian cancer is classified into many, many different types. So this is not one disease. But broadly, they're classified into these three main groups. So the germ cell cancers, which certainly arise in the ovary, these sex cord stromal tumours, which also arise in the ovary, and then importantly, this group of epithelial cancers. And you can see that they account for about 90% of the cancers. So overwhelmingly, this is a really important group, and these are the ones that are shown here. And each wedge represents a different type of these epithelial ovarian cancers. So if you picked up pretty much any modern pathology text, the breakdown of the epithelial cancers would be into these four main groups, maybe a fifth, including low grades. So mucinous, endometrioid, clear cell, and high-grade serous. And these ones here, which I'm showing as 60%, we now understand they account for about 70 or 80% of the epithelial ovarian cancers. So I'll mention these a few times. High-grade serous, they account for about 70 to 80% of the deaths from ovarian cancer in total. And the view was that all these different types of epithelial cancer had their origins in this lining of cells on the surface of the ovary, this ovarian surface epithelium it's called. And so in summary, what people believed was that these were the common types of epithelial cancers, the common types that occurred in most women, and that they arose on the surface of the ovary, and they are all related to each other. So our view of that now has changed completely in the last few years, and it's summarized on this slide. I guess the key take-home message is that for these epithelial cancers, which account for 90% of the cases, and some of them, like the high-grade serous, which account for 70 to 80% of the deaths, that they actually don't come from the ovary and that they're very different to each other. So here they are again, the mucinous cancers, the endometrioid, clear cell, and high-grade serous. Mucinous cancers actually don't arise in the ovary. The vast majority of those, only maybe a few percent, come from the ovary. Most of them actually come from the stomach or the appendix or the large bowel, and they spread to the ovary. These two, endometrioid and clear cell, come from cells that line the uterus, and they move up through the fallopian tube and spread into the peritoneum, into the tummy space. And in some women, they develop endometriosis, and for a minority of those, they go on to develop these types of cancers. So these cancers actually originally come from cells that line the uterus. And then this high-grade serous group, which is such an important group, we now believe that most or maybe all of them come from the end of the fallopian tubes. So the fallopian tubes turn out to be very important, either as a source of these high-grade serous cancers or as a route of spread of these cells up through the fallopian tubes and into the abdomen. And that's important because tubal ligation that some women have can stop that event occurring, and if they have their tubes removed, it stops this source of cancers. Now, why might that be important? they're sort of summarised in these 4 bullet points here. First of all, we now understand that treatments need to be specific. This sort of one-size-fits-all approach to treatment is really not going to help us in the future. It turns out that genetic risk factors, genes that you might be born with that confer risk, associate with these specific types. And this helps us now understand who should be offered genetic testing. We can't understand the biology if we mix all these things together. And knowing where they come from, whether they're coming from the fallopian tubes or from the uterus, very strongly influences strategies for prevention, particularly in people that are at high risk of developing the disease. So I just want to give you a couple of examples of how this is practically important. So we now know that these cancers that are associated with mutations in these genes which increase the risk of developing ovarian and breast cancer a lot, those cancers arise in the fallopian tubes. So whereas in the past the focus for risk-reducing surgery was on removal of the ovaries, that should definitely include removal of the fallopian tubes. And this is obviously a very significant operation for a woman, particularly if she's not yet gone through menopause. So there are now questions about whether the fallopian tubes should be removed alone or whether they should be removed first, which won't force her to go into surgical menopause, and then maybe the ovaries later. And so the field at the moment is trying to figure out how best to manage this sort of genetic risk that occurs in women that carry these mutations based on our improved understanding of where the cancers come from. Here's another example of why it's important. This is a patient who had an ovarian clear cell cancer. So these are the ones that come from the cells that line the uterus and develop from endometriosis in some women. And the molecular studies that our lab and others have done have shown that these don't look like other ovarian cancers, but actually look like a type of kidney cancer. And there's not time to go through this, but this is an example of a woman who was treated with conventional ovarian cancer surgery and chemotherapy and had a very short period of remission from the disease. And it came back as seen by this rising CA125 curve, which is a marker that many of you will know about. And she was very successfully treated on a drug that's used actually in kidney cancer, this drug called sunitinib, and had a very long response to that. That doesn't happen in all the ovarian clear cell cancers, but it's a good example in this patient of how we can learn from leaving aside anatomy and thinking about what the molecular similarities are between these different types of cancers, and the fact that this cancer really doesn't belong with the other types of ovarian cancer. Okay, so let's now talk about genes associated with genetic risk, and I've already touched on this a little bit by mentioning the BRCA genes. So the first thing is, what exactly is a gene? And this seems like such a difficult and abstract concept, but it's hopefully in the next few slides it'll help demystify it a little. So our genome, all our genes are collectively called our genome. So you'll sometimes hear about sequencing someone's genome, and it basically means sequencing all the DNA that represents their code, if you like. And so DNA is actually a physical thing. It's not some sort of abstract idea that we dreamt up. This thing that looks like a hot dog is actually many, many thousands of times enlarged, a bacteria that causes traveler's diarrhea. And spilling out of it, because it's been sort of crushed, is this beautiful sort of long, sinuous, strandy thing that looks like wool, and that's actually the DNA from the bacteria. So all living organisms need this instruction code in order for them to grow, and this is just a segment of it. And the A, G, T, and C are the 4 chemicals that are key to allowing the cell to read and interpret the instruction code. Now, we have a lot more DNA than a bacteria, and obviously it needs to be parceled up so that it doesn't clutter up the cell, and it's organized into these chromosomes. And so we have 22 what are known as autosomes, and then an X and a Y if you're a male, or 2 X chromosomes if you're a female. And they're organized in these structures, and they're just numbered in terms of the size of the chromosomes. So one way to think about this is that essentially it's an instruction code, and I often show this slide when I'm giving a talk, and it's a real demographic for the group to see who can decipher it. And so someone usually puts up their hand, as long as they're over 50, and says, oh, that's a knitting pattern. And so this, if you look at it, this is a code that allows you to make something that looks like this. And so in the same way, this is a piece of code, the DNA sequence from a person, and instead of making the jumper, it makes the person, basically. And so we have a lot of this code in us, 3 billion letters, in fact. And so if you took this text and wrote it down from one cell, it would cover the floor of the MCG. So that's a lot of software code in every one of the cells, and it's been part of the reason that it's been very difficult to figure out how cancers work, just being able to interpret that code. So let's talk now about ovarian cancer genetics. So this is obviously a very technical diagram, but the point of showing it is that these two genes, BRCA1 and BRCA2, are instructions for the cell to make a particular protein, so the BRCA2 protein and the BRCA1 protein. And they're part of a nanomachine, which is depicted here, that can repair DNA with very, very high fidelity when a mistake is made. So you can see BRCA1's here and BRCA2's over here. Now the other point of showing this is that just like a watch doesn't just have a spring and you know, a cog, it has other components. So does this machine have these other components in them. And we're now realizing that mutations in other genes here, particularly say PALB2 or some of the other ones that are shown here, they also can confer a risk of developing ovarian cancer. So one thing that you may hear of is not just testing for BRCA1 and BRCA2, as we call them, but some of these other genes to see whether someone might be carrying a mutation in those, even when these ones might be normal. So until recently, we've thought that, as I said, that we know that these are involved in DNA repair, and some people are born with one defective copy, and then if you lose the other copy, that's when the cancer is very likely to develop. And it was thought that the frequency of these mutations in people with ovarian cancer was about 5 to 10%, and that genetic testing, the offering of genetic testing, was really based on family history and to a small extent on the age of diagnosis. And really our work and some other work from overseas has really changed the view of that quite radically. So we now know that the frequency of these mutations is much higher than 5 to 10%. It's nearly 20%, but it's almost all restricted to these high-grade serous cancers. Should the genetic testing guidelines be changed? Yes, and they have actually as a result of this work. So what we found was that nearly half the people that carried these mutations didn't have a strong enough family history to have been offered genetic testing in the past. So now we offer testing to any woman who carries one of these high-grade serous cancers. It's important to do it early because it can influence the way that drugs are chosen, and we know that these patients respond best to certain types of chemotherapy. And it's very important for people to know because if there are other members of the family who've not yet developed breast or ovarian cancer, we can cut that risk down significantly by detecting them before that cancer develops. So it's of real value to the rest of the family. That's something we're working on more at the moment. So I just want to finish off in the remaining few minutes and talk about some of the genes that influence the response to treatment very quickly. So again, this is a very complicated picture, but it just shows a paper that we're very proud of from our lab with a lot of collaborators here in Australia and overseas, that was the first effort really to look at the evolution of high-grade serous cancers and how they develop resistance to chemotherapy. And again, it's a bit too technical to show it, but basically one of the things that we found in these patients was that their cancer had activated a pump so that when the cancer came into the cell, was pumped out sort of as rapidly as it accumulated and allowed the cells to become resistant to the chemotherapy because it was being pushed back out. this sort of work is based on sequencing of cancer gene of patients and their cancers, and it generates an enormous amount of data. This study generated nearly 100 trillion bits of data, so lots of computational work to work through the data and to find these sorts of events. There's a mower going on outside. Hopefully that's not coming through. So I'll just finish by mentioning this really interesting study, which is a study called MOCOG, which is an international consortium that we're lead members of, or one of the leading members of, and we're looking at patients who have an exceptional response to treatment. So patients who we normally wouldn't expect to survive their disease, who are still alive years later. And we're trying to understand the influence of how the genes they're born with and the genetic changes in their cancer might interact with their lifestyle, for example, their diet and exercise and well-being, as well as their immune system. And so this MOCOG consortium is kind of taking apart these cancers to really try and understand how some of these women, against all, really beat the odds, and whether we can learn from that and use that information to guide the treatment of women who have a more typical course of their disease. So just to summarize then, I think we've got now a much better idea of the nature of ovarian cancer, where it comes from, the importance of recognizing the different types and developing therapies for the different types of ovarian cancer. We've got a strong handle on the genetics, and that's led to a change in the genetic testing guidelines. We've completed a blueprint of the mutations that are common in the common forms and the rare forms of ovarian cancer, and we can see new targets for therapy. And we're doing a lot of work on trying to understand the evolution of the cancers and how originally sensitive cancers to chemotherapy become resistant. So I think that's my last slide, and I'm happy to take any questions, or do we move on to Robin now? I'm not sure.
Thanks, Professor Bertel. So we have a couple of questions that have come through. So the first question is from Robin. Now, is this significant for somatic mutation of BRCA1 and BRCA2?
So somatic, just to let everyone know, there are sort of broadly two types of mutation. There are the mutations you're born with. They're called germline mutations, and they're involved in inherited risk. And then there are somatic mutations. They're mutations that can occur in the cancer itself, but don't affect the rest of the patient. And those mutations are not transferred to daughters or sons. So that's an important distinction. Somatic mutations in BRCA1 and 2 are important in terms of the likelihood of a patient responding to certain types of chemotherapy, but they're not important in terms of germline risk. So the key thing is to understand their value to the individual patient in terms of how she might be treated with chemotherapy. But the happy news is that if you're carrying a somatic mutation and not a germline mutation, that mutation will stop with that cancer. It won't be passed on to the next generation.
Thank you. So the next question is from Chris. Are steps now being taken to remove the ovaries, etc., whilst having a hysterectomy in women over 50 to help prevent ovarian cancer?
Right. Yeah, so now that we know that the ovaries are important, the fallopian tubes are important for the development of these cancers, then yes, that is starting to happen. So we're pushing this information out into the clinical community so that they understand the value of doing that. And then around the world, there are some structured studies doing where we're trying to actually collect the value of dissemination of that information and see whether it actually drops the risk of developing ovarian cancer. But the bottom line is that any woman who's having a hysterectomy or having a tubes tied the ends of the fallopian tube, if she's finished with having her family, she doesn't want it reversed, the ends of the fallopian tube should definitely be removed because they can become a source of cancer.
Thank you. So I have a comment from Dawn. I am involved in the Opal study out of Queensland. This may help with the study of survivors over 10 years. Thanks for that comment.
Yes, that's right. So Opal is a study that's led by Penny Webb, who's part of the Australian Ovarian Cancer Study as well. And so Opal patients are feeding into that last slide that I mentioned, the MOCOG consortium, to try and find these long-term survivors and to understand how they beat the odds. So yes, Opal is part of that study.
Thank you. A question from Maureen. A diagnosis of low-grade serous in 2014, followed by genetic testing, which resulted in an indecisive result. Should my sister be tested? Thank you.
Right. So low-grade serous cancers are generally not associated with these inherited mutations, or at least the common ones like BRCA1 and BRCA2, or the other parts of that machine that I mentioned. The best thing to do in that situation is that information is being constantly updated as we learn more and more about the changes that are significant or not significant. So what I suggest you do is to have a conversation again with someone in a familial cancer centre who can help interpret the information that was found in your case against the current best guidelines and to make some recommendations for your daughter. But at the moment, low-grade serous cancers are generally not associated with inherited risk, but that's not completely the end of the story, but mostly that's the case.
Thank you. A question from Barbara. I have a granular cell tumor, first diagnosed in 1998, with recurrences in 2007 and 2015. Is there an inherited risk with this type of ovarian cancer?
I don't actually work very much on granular cell tumors. I think the answer to that is mostly no, but my knowledge is a little bit out of date. There's a particular type of somatic mutation that's very, very common in granular cell tumors, but that's generally not associated with inherited risk. But again, that's a conversation to have with a specialist in a familial cancer centre.
Thank you. We have a comment from Chris. Yeah, I am very happy about this. Wish it was done with me, then I probably wouldn't have OC. Okay. Then there's a next question from...
One comment that I just might drop in there is something that we're working on actively on at the moment. In fact, when this is finished, I'm going to go back to the grant that we're just about to submit to NBCF, is to try and find individuals and their family, the next of kin, who predated the change in the genetic testing guidelines. So it's great that going forward we have this knowledge, but we actually need to do something about the patients who predated those changes in the guidelines and their family. We just feel that it's unacceptable to just wait until one of these mutations makes itself known by someone else in the family developing the cancer. So we've got a project called Traceback, which we're developing here in Australia, and I hosted a workshop in the United States 2 weeks ago to try and develop a strategy within North America to do that as well.
Thank you. So we have a comment from Cheryl. With doctors not wanting to perform a hysterectomy before 40 years of age, should younger women look into removal of fallopian tubes once they have finished their families? My daughter is 36 and I have had breast cancer 2006 and ovarian cancer 2015. We have found out we are both BRCA1.
Right. So certainly your daughter is at increased risk, and once she's had her children, it's very important would be very important, I think, to consider having her fallopian tubes out. That's a conversation that she can have with a gynecological oncologist who should be familiar with all the background details. I always hesitate to comment on individual cases because I haven't seen the clinical histories for those patients, but I would think, given that you're both BRCA1 carriers and your daughter's young, and given your history, then if she's had her children, then she should definitely consider that.
Fantastic. So Jeanette's also made a comment. I have sent my consent form to your author to participate in the investigation of long-term survivors, but haven't received a confirmation that she has received it. Can you follow up, please? So I'm not too sure if that's directed to you or to OCA, but...
It'd probably be directed to me because we're running the study. So, Jeanette, if you send me an email, then I'll be able to pass it on to Cass Alsop, and she can feed back to you exactly where we're at.
Thank you. So we have a question from Karen. I'm a strong advocate for genetic testing and have been diagnosed with Lynch syndrome. I'd like to offer to be a guinea pig for further investigation. Are there opportunities for doing so?
Probably the best person to talk to about that would be Paul James. So Karen, if you also email me, I think my email should be made available through OCA, or certainly you can find me on the web, d.botel@petermac.org. I can forward that question on to Paul, who is a clinician, an oncologist in the Familial Cancer Centre here at Peter Mac.
Thank you. Okay, so we have a comment from Cheryl. I was diagnosed 2 years ago and nobody mentioned genetic testing to me. I recently made inquiries myself in Queensland and was told that the guidelines have changed, and at 65 I was able to have done this and all is good.
Good. No, that's great. Well, those changes in the guidelines really came from I think in Australia particularly, really came from the work that we published back in 2012, which pointed out the importance of testing or offering testing to all women with epithelial ovarian cancers, essentially, except for the ones with mucinous cancers where the mutations don't occur. And what was really pleasing was that the guidelines actually changed in 2013, and because the community, the clinical community in Australia is very interactive and cohesive, that change in the guidelines has been propagated fairly quickly. It's not perfect, and we're working on trying to make that better, but in Australia the uptake of that has been really quite fast. So I'm glad to hear, Cheryl, that was sorted in your case.
Thank you very much. Okay, so thanks, Professor Botel. What I'd like to do now is I'd like to invite Robin Dennis to share her story. Please go ahead, Robin.
Good morning, everyone, and I'm really grateful to be here to be able to talk to you today. And I'd just like to say thank you very much to David for demystifying some of the science for us about ovarian cancer and how it affects us. So what I'd like to talk to you ladies today is about how that translates to you and I on a personal level. And I'm very humbled to be able to share my story of what my experience has been with ovarian cancer. And I was interviewed recently for another reason and described myself as ordinary, just an ordinary housewife that was diagnosed 4 years ago with high-grade serous epithelial ovarian cancer. I heard someone speaking on the weekend that said, well, we're not just ordinary, we're extraordinarily ordinary. And I'd like to think that's just the case, where this cancer just affects ordinary people. It's not something that happens to somebody else, it happens to us. And that's a difficult concept sometimes to understand, that it is just, the risk of acquiring this is just being a woman. So if you'll indulge me, I'm going to share a little bit about my story and how I was diagnosed with the disease. So I was 48 years old and really didn't have any of the classic symptoms of bloating, needing to go to the bathroom frequently, those sorts of things. I'd been fatigued for some time and I wasn't really concerned about anything seriously wrong with my health. I presented to the doctor just to have a check, and everything was fine. Blood tests were all normal, all the standard tests were fine. I had presented with a very small nodule in my navel, which the doctor at the time said, oh, it's probably just an umbilical hernia. And I went away thinking, no, I'm all good. I'm just busy because I've got 3 children, I'm premenopausal, and that's what's making me tired. So 4 months passed and the nodule increased in size, and another doctor was quite concerned about it. So I was sent for some testing. I had a biopsy done and it was shown to be malignant, and from what they thought was a gynecological cause. So that was a very difficult piece of news to receive, and it was news that I received over the telephone. So 8 o'clock one night, 28th of June, remember the date very clearly, I had a phone call to say that was what had happened. So the following week was a week of a lot of tests, which I'm sure many of you have had, CT scans, ultrasounds, blood work, and again told over the telephone that in fact it was ovarian cancer. So surgery followed by the standard protocol of chemotherapy, which I found incredibly difficult. I'd had an allergic reaction to Taxol, and just mentally found the challenge of getting through chemotherapy very difficult. So fortunately, I had a wonderful doctor who did get me through that 6 months, and I then was fortunate enough to have a 2.5-year remission, in which time I was very well and I lived very well. Unfortunately, my CA-125 started increasing again slowly at first and then quite rapidly, and I was found to have had a recurrence of the cancer on my right lung with a pleural effusion. But again, being a little bit unique, it was only found to be there, and I had no disease in my peritoneum or the usual places that this cancer likes to hide. So from July of 2015, I had a further 7 rounds of chemotherapy of carboplatin and calyx, and finished that treatment. Hello? Giano?
Yes.
Sorry, I've just lost my connection at this end. Are you still,
We can still hear you, but we've just lost
I can hear you, Robin. We can't see you.
Oh, okay, that's fine. That's probably a good thing. I'll still just keep talking then. So yes, I had finished my chemo in January this year, and I was offered, I had previously had the BRCA1 and 2 genetic testing that David discussed earlier. And
I was people offered, that are actually saying that the sound's gone, picture gone.
Everything's gone, okay.
No, so we can actually, I can confirm that audio is still coming through.
Sound okay.
Okay. Mm-hmm. Okay. I don't know what's happened on my end. It just came up with a message. My computer said it detected a threat. So I'll still keep talking. So I was offered to take part and have testing done for somatic mutation of BRCA1 and BRCA2, which was like someone talking another language to me. I'm an accountant by profession, so not really all over the science of this sort of thing. So I have since had all of that explained to me, and I was very unsure as to whether to proceed with that testing or not, because these currently come at a cost. And many decisions have been made along the way during my treatment as to whether I would have certain drugs that were going to cost and tests that were going to cost, and this test came at a cost of $1,200. So finally, I agreed to have the testing done, and I was advised only a week ago today that I actually was positive for a somatic mutation of BRCA1. So where that leaves me now in terms of future treatment and plans is still a little bit up in the air. I think there will be decisions that have to be made as to whether I opt to start taking some of the drugs that are available, which come at quite considerable cost. So because of all of those things that I've experienced, I've become very passionate about trying to support other women who are going through the same, on the same pathway, so to speak. I understand from what David has spoken about this morning that ovarian cancer is not one disease, and in fact is a subset of different diseases. But from my perspective, whilst our clinical paths are very different, and I think it's really important because I have been guilty of this in the past, we meet other women with ovarian cancer and we become concerned that the way their disease progresses may be the way our own progresses, which is not the case, and our clinical paths are very different, and that's why you'll hear so many wide and varied stories. But our commonality is the impact that it has on our lives and those of our family and our close friends, the fear of our future and the fear of treatments and what is coming next is always with each and every one of us. And I think there can also be an isolation, and not necessarily in that you're alone. You can be surrounded by family and friends, but the isolation of feeling you're the only person with this disease. Having said all of those things, I have found that there are so many positives that have come out of my diagnosis. I've had the opportunity to meet some incredible people and made many new friends. I've had the opportunity to speak to many groups of women about my story, which I still think is very humbling that people want to listen to my story. And a diagnosis can bring a very positive change in the way that you choose to live your life. I've been fortunate that I have had 47 months since my diagnosis of exceptionally good health, despite having retreatment. I have been able to see my son graduate from university, my daughter finish school, leave home and head off to uni, and I have one more son who is only 15, and I would love to be here in 2.5 years to see him also finish school. So essentially what I want for the future is I want hope, and the kind of research that David talks about I think gives all of us hope. Hope that there's new treatments that are going to become available, new ways to deal with each woman's cancer individually. The fact that there could be an early detection test at some point in the future so it never even gets to the advanced stage that so many of us are diagnosed at. Even possibly an understanding of why this cancer has struck us. So all of this knowledge, I think, helps us to live with this disease. I have never referred to myself as a survivor, and I incredibly dislike that term. This disease is chronic. It doesn't leave us, or most of us, and I think you have to learn to live and live well with it. So I feel that through the work of Ovarian Cancer Australia, we need to come together and have a voice. So whenever I get the opportunity, I like to participate in forums where we have interested parties come to the table. So representatives from the PBAC who decide which drugs become available on the PBS, from specialists, clinical nurses, support staff, because I think there's still a long way to go in dealing with the women who currently have this disease and providing ongoing support to us, having someone that we can contact who can navigate us through some big decisions. And I think most of all, we still need to get ovarian cancer on the map. It's happening, and I think this year has been so exciting to see some new initiatives like the ones that David has spoken about, and even just the amount of media coverage and awareness that is out there now. Women are starting to understand more and more about this disease, and hopefully that will help prevent more women being diagnosed. If women know what the symptoms are, what they should be looking for, know to go to their doctors, ask the questions, ask about family history, if there are any members of their family who do carry this gene, and then know how to act accordingly. And if they're not getting the appropriate answers from their doctor, then to go again or go and see a different doctor, because we are the ones that have to be empowered to look after our health. And I think in that respect, all of us need to put our voices together to make sure that ovarian cancer awareness is one of our main priorities. So on that note, I think that's probably most of my story, and unfortunately I now can't see any questions on the screen. My computer has completely let me down here. So Gianna, I don't know if there are any questions.
Okay, so a few questions have come through. Now, Jeanette just asked earlier, didn't you have a hysterectomy? So I guess clarification.
Yes, I had a full and complete hysterectomy in 2012 when I was first diagnosed.
Thank you. Now, Dawn is asking, what stage of was your cancer?
Stage 4.
Stage 4. Fantastic.
Yeah, and it was stage 4 by technical definition. It was detected quite early because I had this small secondary metastases which actually led us to the cancer. So when I was operated on, there wasn't extensive disease, but unfortunately it's stage 4 by the nature of it being metastatic.
Thank you. So Marie, she has stated that, yes, I agree with the fear and the isolation. And now Dawn is also saying, I am hopeful for... Oh, yes?
So just comment on that, Marie. I think that's one of the things that I hear most from a number of women. And I live in a regional area of New South Wales, and when I was first diagnosed and was looking for support, it was very thin on the ground. And so after 2 years of doing a lot of persistence with a local group, I managed to actually get a support group up and running where I live, which I now facilitate. So there's a group of about 6 or 7 ladies, and it always struck me that the first time we met, one of the women said that was the biggest thing that she found was the isolation, despite having close family, children, fantastic friends around her, was that sense of isolation. She didn't know anybody else that had cancer, let alone ovarian cancer. So I think overcoming that isolation and having support is absolutely vital.
Thank you. Now, Dawn has also made a comment. I am hopeful for the possibilities of PARP inhibitors as being available as a treatment.
Yes, well, that's the type of drug I'm talking about that I had discussions with my oncologist about, given my recent positive result with the somatic mutation testing. At the moment, for people in my position, they are expensive, and I don't know if I'm allowed to discuss exact amounts on this in this particular forum, but I'll just leave it to say that there are decisions to be made, and that disturbs me that women are put in that situation where decisions need to be made, and it shouldn't come down to a financial decision from our perspective. As an economist, I understand how much research and money has gone into these drugs being produced, and I understand they can't all be free. However, from our side of the table, it's very difficult to know that there is something available which is not accessible to all women who it may be able to help.
Thank you. Now, Chris has made a comment. Robin, none of us are ordinary. We are all individuals, and you're right. Each woman has a different journey. We're not all the same when diagnosed. Your comments are inspiring. The impact on our families, diagnosis, and the isolation we feel. It's wonderful that we have great support through Ovarian Cancer Australia and the Cancer Council, and the word is getting out about this cancer. Stay strong.
Well, thank you very much. That's a lovely comment, and that's my sentiment exactly. And look, I'm sorry that I probably have been a little bit. I normally would be a lot better prepared. I think today I've had a disturbing week of having CT scans and blood tests and doctor's appointments, and I'm just about actually to head off to another one once his webinar is over. So I'm glad that she's found something inspiring out of my story. I think that. We women, when we're together, we're a force to be reckoned with. And I had the opportunity on the weekend to attend the High Teal with Judith Lucy that was held in Sydney on the weekend. And yet again, just an amazing group of women. And that's actually where I heard the term extraordinarily ordinary, which I just loved. So to Tanya, who got up on stage and described all of us women like that, I just think take my hat off to you. So, yes, I'm glad that there's been something a little bit inspiring in what I've had to say today.
Thank you. Now, Sue has also made a comment. I have stage 3 ovarian cancer, and she does have questions. So, Sue, perhaps you could follow up with an email to Robin or to the ovarian cancer, who can forward it to Robin, who can help answer those questions for you.
Yes, if I can. I mean, I can't answer anything of a technical nature, but in terms of anything that I've discussed this morning or in getting through this whole process, then yes, certainly. As I said, I have no medical knowledge. Everything I do know about this disease, I have read about, I've inquired about, and I think actually that's one more comment that I would probably like to make to women out there, is that don't be afraid to question your doctors. Don't be afraid to ask what you want to know, or to be told, to be telling them you want to be told the truth and not have things sugar-coated. And I've always been very adamant. I've probably annoyed some of my specialists along the way, but this is our health and this is our life, and I think we have the right to have as much information as we wish to know. Some people don't want to know, and that is absolutely fine. For me, I've always found that knowledge has helped me understand what I'm going through and try and make informed decisions about what I'm yet to go through. So I always suggest to women, if you're unsure about something, ask the question. Just really push your point forward and make sure that you're happy with the treatment that you're receiving and that you're happy with the information that you're being given.
Thank you. We have a comment from Cheryl. I would love to meet with other women at conferences of some sort. We need this to be able to grow in all areas of support, understanding, help, etc.
Yeah, and as I said, I have found a great lot of comfort in that. And Cheryl, just keep in touch with OCA, make sure you get their newsletter and be on their mailing list, and when those opportunities come up, they'll certainly send out information. And it's great. The more voices we have together, the louder we'll be heard.
Thank you. Denise has suggested join a support group if you can. It is helpful to be able to talk to people who understand.
Yes, I know exactly what you mean, Denise. And if it's the Denise I'm thinking about, we've had many conversations over the telephone across the years and provided support to each other. And that's just invaluable. There's no price you can put on the ability to be able to talk to somebody else who's walking in your shoes, and you don't even need words. You know exactly what the other one is feeling and going through, and it makes a huge difference.
Thank you. Now, Dawn has mentioned in 2012, I was involved in a project out of Flinders Medical Centre in South Australia called Finding My Way, an online support for newly diagnosed, especially for regional people.
Oh, that sounds fantastic. I'm glad that there are places, I haven't heard about that particular one, but I think that's fantastic that there are, local and regional areas doing things to support women in their area.
Now, Cheryl is asking, it is very disturbing that you talk about the money influencing decisions. This is something that we should be able to fight for together. Also, can you get your money back from the genetic testing because you are positive to BRCA1? Just because I had enough cancer in my family to meet the criteria, but my testing cost me nothing. It does not seem fair. I should say that the cancer in my family had no influence on my BRCA1 result, and it came from a different line of my family.
The original BRCA1 and 2 testing I had done for germline mutation was done at no cost when I was first diagnosed. David may know more about this. I don't know a great deal about it. This recent one that I had done where they're looking for a somatic mutation is probably not a standardised practice yet, and I think it was offered through the pharmaceutical company who is marketing the PARP inhibitors. So it may be a little bit unique, and that's probably why that is at this time associated with the cost. But I agree with Cheryl, it shouldn't be a decision. Someone's ability to pay for these things shouldn't equate to their quality or length of life.
Thank you. Now, Sue is asking, do you know how much about Keytruda as an immunotherapy trial in OC?
No, I'm sorry, I can't comment on that. It's not something that I've ever heard about even being used in ovarian cancer, but David may know more about that, but I certainly know nothing about that one, sorry.
Yeah, so Keytruda is a drug called pembrolizumab, and they've got long names, but basically it's one of these new classes of immune checkpoint inhibitors that have shown extraordinary success in lung cancer and melanoma and some other cancers. And at the moment, where the field is trying to push those into other more common cancers, including ovarian cancer. So we have a protocol submitted with the company that makes Keytruda to consider a clinical trial in exactly that area. And there are similar trials there's one that's underway in Sydney and some sites in Melbourne with a similar kind of drug. And I think that we'll see quite a few of those trials. At the moment, though, essentially the process is that a trial needs to show a benefit of a new drug in patients before it can get registered in Australia and then get onto the PBS, where it essentially becomes free to patients. So the only way that people are going to access those drugs in the next few years, really, until that sort of benefit's shown, is through clinical trials. Unless they pay for them, as it's been sort of discussed.
Thank you. Now, Karen is asking, I had a similar experience when I was diagnosed. No local support in country Victoria. Started a support group and now have approximately 13 women getting together once a month.
Oh, that's fantastic. And I'm sure that you're all reaping the benefits of that. And I think I get as much out of it having set it up as hopefully every one of the women who come along. So that's fantastic, Karen, that you've done that, because there's 13 women who are very grateful for, I'm sure.
Thank you. So Sue is asking, I am now up to my third recurrence with following chemotherapy. Do you know of women in Australia who have lived past the 5-year survival rate who are not connected to BRCA gene?
Yes, I actually personally know some that are in that situation. So yes, so there is always hope, Sue, always.
Yeah, I can comment there too. We certainly see that in our study of long-term survivors, although patients with BRCA1 or 2 mutations generally have a better response to treatment. Certainly there are women who have survived out to 10 years that don't carry those mutations, and beyond 10 years.
Thank you. So I can see that Jeanette and Sue have made comments. So Jeanette says, I've survived 11 years, no BRCA gene, still being treated on chemotherapy. Sue, on the other hand, has directing to Sue C. I've had 3 lines of chemo in 2 years. Now platinum resistant. I will soon be starting an immunotherapy trial of BGB A317, an immune checkpoint inhibitor targeting PLD1. They want to recruit 20 women with higher grade serous OC. Ask your oncologist about this trial.
Yeah, so that's the Beijing trial that I mentioned that's based in Sydney, but I think it's recruiting also in Melbourne.
Thank you. Denise also states that it will be 7 years for me come October, still fighting as hard as I can.
Yeah, I've certainly met quite a lot of ladies with ovarian cancer since I was diagnosed, and yes, I certainly do know a number that do not have a genetic mutation who have responded well to treatment and have always remained positive, and I'm always amazed at their resilience. They can, how so many of them, well, many of us have setbacks, and we just keep on going. And that's what I was talking about earlier, about living well with this disease. And I can remember it being described to me by an oncologist once as, it's a chronic illness. And I remember saying back to them something like, well, yeah, it's not quite like diabetes or something else. It's a little bit more serious as a chronic illness. But it really is, and if you can keep responding to drugs and keep fighting and living well. I think for me that is the key, is really trying to live well when we're not on treatment, and really cherishing those times and getting involved with everything that you can in your life during those times when you're not on treatment.
Thank you. So Sue has also mentioned that she would like to finish with encouraging families to attend an annual walk with her. That she's an event that she started this year. It is held on the last Sunday of February, and the website can be found in the chat box at this very moment. Sue also says she's asking, requesting, can I have a contact for Jeanette or any survivors? Denise, 7 years. She's remaining positive, and believe her.
Yeah, I imagine that Ovarian Cancer Australia might be able to organise something like that, or, yeah, I don't know, but that's a question perhaps for them at some point.
Okay, so we'll take this as the last comment, as we are running out of time. But from Maureen, living in Perth, I am part of a study of exercise and OC survivors, which is having great results. Also, my genetic testing, WA, was free, and diagnosis and aftercare has been outstanding. She is very positive.
Yep, that's fantastic.
So thank you for all your comments and all your questions. Now, the OCA would like to thank you, Professor Bertel and Robin Dennis, for your presentation, and thank you to everyone for attending today's webinar. Your feedback is really important to us, and it helps to inform and assist with the future development of our webinars. Please stay logged in to take our online survey, which you will be redirected to shortly. We thank you in advance for your feedback, and we wish you a pleasant afternoon. Now, don't forget to register for our next webinar. Details will be emailed to you and available on the OCA website. This webinar will be available in the next few weeks on the OCA website to view on demand. Thank you.
Thank you.
Everyone.